Okay, thank you everyone for joining us today for our COVID facts and best practices webinar. We wanted to hold this event to have an opportunity to kind of share information on the pandemic and OCU's response to it, how we're handling things. We open this up to students and parents of students. So if you're new to the OCU community and may not be familiar with some of our practices as it relates to the pandemic, this is a good chance to kind of learn how we're handling things here on campus. We have a small panel here, but a motivated and excited panel, and everyone is playing a role to kind of help try to keep our campus safe. And so I want to just take a second to introduce our panelists and just give them real briefly a chance to say hello to everyone. I'll kind of go around my screen and start with Antonia Pratt-Reid. Tony is an advanced practice registered nurse, a certified nurse practitioner, and she runs the campus clinic on OCU. So if you would, Tony, say hi for a second.
Good afternoon, I'm Tony, and my role with OCU right now, besides doing all of the school immunizations and wellness exams and illness exams, we now manage the COVID testing for OCU, both the surveillance, getting into school. So I've met hopefully many of you, as well as the surveillance through the semesters and illness COVID testing. So I'll look forward to talking to you just a little bit later.
Thank you. We have Levi Harrell joining us. He is our Dean of Students, and he's a member of the COVID Emergency Operations Committee on campus. Levi, if you would, say hi to our guests today.
Good afternoon, everyone. My name is Levi Harrell, and as Nick mentioned, I'm the Dean of Students here at Oklahoma City University. I represent the Division of Student Affairs and Student Curricular and Co-Curricular Activities on the university's Emergency Response Committee. I also work very closely with our students, faculty, and staff should the need to isolate or quarantine arise.
Thanks for that, Levi. Wendy Lentz is with us today. Wendy is an adjunct faculty member in both our College of Arts and Science and in our physical therapy program. And she, more directly related to COVID, is the campus COVID coordinator for our Emergency Operations Committee. So Wendy, if you would say hi.
Absolutely. Hi, everyone. Thanks for coming out this afternoon. As Nick said, I'm a didactic educator of anatomy and physiology courses in the Department of Physical Therapy and in exercise and sports science. I'm also a certified athletic trainer, and I'm the COVID coordinator. I do a lot of the data intake and a lot of the data management on campus with, so I spend a lot of time on the phone with a lot of you talking about COVID-19 issues. So please let us know if you have any questions today.
Thank you. And then finally, we have Dr. Jennifer Clark, who is our featured panelist and presenter today. Dr. Clark is a member of the Oklahoma Project ECHO as it relates to COVID-19, and that's a project from the Oklahoma State University Center for Health Sciences. I'll let you just give a real brief intro of yourself, Dr. Clark, and we'll have more time to come back to you here in a couple of minutes, so take it away.
Sounds good. Thanks, Nick, and thank everybody for inviting me to be here. As Nick said, I'm a physician. I'm located in Tulsa, but work not only in Oklahoma, but worldwide on the COVID-19 pandemic and figuring out novel ways to kind of handle that. So I'm really glad to be here and be part of your community's conversation. So back to you.
Thank you for that. I'm going to go over just a couple quick business items as it relates to COVID and what we're doing at OCU. The first thing is just a reminder that if you're here taking part today, feel free to submit questions. We're going to have a presentation that Dr. Clark will provide today, and after that, we will have time for a little Q&A. So if you have questions, feel free to submit, and then we'll try to get to as many as we can after the presentation is complete. I want to touch just for a second on something that a lot of people ask us about, and that is our mask policy at OCU. So our current policy right now is that we are strongly recommending masks in our indoor spaces. I want to bring that up, just a note that we get a lot of people asking, well, why don't you mandate or require masks? And some people don't know there is a new state law that went into effect at the start of July, which essentially limits our ability to take steps like that. And so that's the reason why we have not all the way gone back to what we did in the spring and last school year, where masks were required. I just want to let everyone know that our school administration and legal counsel is obviously trying to stay up to date on what's happening with that law. There are legal challenges to that law right now. And so that's all I'm going to say about that at this time, but I thought that was good for clarification in case you're wondering, well, why don't you just, make them mandatory? There's other factors at play there. But due to the ongoing nature of legal challenges and whatnot, we're not going to discuss that any more than just providing that bit of information for the group today. So just wanted to put that out there for everyone because we know we've had questions there. The next thing I want to talk about was our vaccine incentive program. That's called the Drive for 85. And we say 85 because what we're shooting for is a goal of an 85% vaccination rate on our campus, both for students and for faculty and staff. We're encouraging anybody who's been vaccinated to submit their vaccination record. And as part of the incentive program, if you're in that pot of people who have submitted your record, you're entered for some pretty cool prizes. And so you can find information on that on our website, right on our homepage. If you scroll down just a little bit, you'll see our coronavirus information page. And all the listings of prizes and how you can submit your vaccine card is listed there on the homepage. Last thing I would want to add to the list here is just that we have a Johnson & Johnson vaccine clinic on campus that's coming up next week, September 2nd. Levi, I might ask, or Tony, are we full for spots for that yet, or are there still space if people want to get in on that?
We still have spots available, and that clinic is next Thursday, September 2nd at 3 p.m. right here on campus in the campus clinic.
Okay, and you can reach out to the campus clinic if you want to try to get a spot for that. And so,
Nick, I would actually recommend folks reach out to me or Student Affairs to register for that, or if they would like the link provided. That just might provide a more streamlined opportunity to register.
Okay. I won't try to ruin your process anymore, I promise, after that. Okay, that's all for sort of business updates for me. Since we have these panelists here today, and there are people maybe who are curious about how we handle COVID cases and instances on our campus, I wanted to give our panelists a chance to answer, to sort of speak to that themselves. And so I want to throw it to Wendy. If you could, Wendy, you mentioned a little bit in your intro, walk through for the folks who are joining us today, the role that you play when now someone on campus thinks, uh-oh, I'm starting to not feel so good. What do I do now? What do we tell people to do, and how do we navigate through that?
Absolutely. So we have a really easy response protocol on campus. You can get a hold of me or our EOC team 3 different ways. You can contact us via the COVID hotline at 405-208-5025. You can email us at notifyeoc. It's all on the website, so it's super simple. Notifyeoc at okcu.edu, or you can respond to us or reach out to us with one of our online forms that allows you to put in a little bit of information, sends it directly to our response team, and we'll reach out to you. So 3 easy ways of getting a hold of us. And Nick's exactly right. If you feel sniffly, if you don't feel well, reach out to me and I'll give you a plan of what you should do. Reach out to the clinic, visit them for a WellCare check or a healthcare check, not a WellCare, a healthcare check. And we'll make a plan for what's going to happen. If you're potentially symptomatic, if you had an exposure, whatever the situation may be, we've got a plan that can help you mitigate the spread and help us with our campus safety and our mission to keep the entire campus safe.
That's really good advice, and I feel like there may be questions. Should I go talk to my professor? Should I go talk to my RA? Should I talk to my friend over here? but really what we want is for people to reach out to the Emergency Operations Committee first, right?
Absolutely. You reach out to us, we'll help you establish a plan. And then from there, we will help reach out to your professors and say, hey, this person needs to be quarantined for a period, or we're waiting on some test results, or we'll just help you make a plan. And as mentioned, Levi and his team will help reach out to your professors and help get you situated in the classroom and do what's necessary. If we do have to quarantine you, we've got a whole team with our housing and different areas that will walk you through the entire process and make it pretty much painless for you.
Sure thing. Appreciate that. Tony, I'm going to turn to you now. And so that's, I guess, sort of like the beginning of the process. If you think you may need to get tested or you're not feeling so well. Walk us through from the clinic perspective now. What should students expect if they need to interact with you guys?
Sure,
as it's
thanks,
related
Nick.
to COVID?
First, I want to talk just a little bit about surveillance because our processes are just a little bit different, two separate processes. For surveillance, you folks are signing up on the portal as planned in your groups, whether you're athletics or performing arts, law school, whatever your specialty is, you sign up on the portal with the time, come in. We do a small survey on you, and then we do a rapid test. And if there are no symptoms and the rapid test is negative, you get an email in about 30 minutes that says the recent test that you had completed is negative and you can go about your business. When you fill out the form, if there are symptoms that you may say, well, you know, I've had a headache or I've had some sniffles or something like that, we're going to talk to you a little bit more in depth. We'll do a rapid test and we will follow that up with a PCR test. And I like to talk about that because although rapid tests certainly have a place, and they're very good for getting a lot of people through and picking up some asymptomatic tests that are positive. When it comes to somebody who may have symptoms, we want a PCR test. And the difference is a PCR test is highly specific and is very sensitive. And although it takes a little bit longer, it gives us more sensitive information. The other thing about a PCR test is that it can actually be further tested for variants. And so the state uses that to track our variants that we are certainly seeing in Oklahoma and that Dr. Clark will talk about as well. So the surveillance goes through the west end of the Kramer building. And we run those tests on a Monday through Thursday for the most part. And you sign up for those and you'll sign up for those all semester. Now, if you're ill, you're not feeling well, you wonder whether or not this may be allergies, Oklahoma, sinus congestion, or whether it's COVID, we are going to schedule you an appointment through the clinic. A little bit different. They're going to work with you in a special area. And we'll take a little bit more of a history, and that's definitely going to take a PCR test. When that happens, we're also going to let Wendy know what's going on so that we can protect you and your classmates and your roommates until we know what your test results are. And that then goes into Wendy, and she will take care of you. If that test is positive, you're going to hear personally from me. Rarely is it going to be one of my staff members, but we're going to talk about what a positive COVID test looks like, how you feel, the progression of the illness, what your needs are, if there's anything particular that you need, if you have an illness that we have to particularly watch for, and you're going to have my personal phone number to talk to 24 hours a day. So we work with you through the whole process. And then Wendy, of course, sees that you're taken care of with housing, and Casey works with you as well. And Levi takes care of your professors. And we hopefully make this process as smooth as possible. Just a little note to tell you folks that this has been one of a work in progress, but something that we have done for the full 17 months and a lot of. Last month, we hit our 14,000 tests that we have done since the beginning of COVID. So we're seeing a lot of them. We're doing a lot, and my staff is well versed in how to take care of you, and we're there for you.
Appreciate that, Tony. You mentioned the phrase 24 hours a day, and I'm curious, we did have a question from a parent recently about what about after hours? What if a student needs to be tested late at night or on a weekend? What is our advice for our community in situations like that?
That's a really great question, Nick. First off, the after hours number is on the OCU website. It is posted on the wall in there as you do your surveillance testing. It is given to the students when I talk to them. So my number's available, again, 24 hours a day. I have taken calls at 3 o'clock in the morning. I take calls at 6 o'clock in the morning. It doesn't matter. We're here to take care of you. So we will reach out to you as we need to make sure that you've got everything possible.
Okay.
As far as the hours, the campus is open Monday through Friday, 8:30 to 5. We have 2 other clinics that have some extended hours. One of the clinics is open on Saturday morning. So if it happens to be after 5 o'clock and you reach us, and we can make arrangements to get you in the evening time. Mondays and Wednesdays are our late nights, but we're still later at the other clinics. We will do that. If not, we'll help you with another source. And then of course, Saturdays, we will be happy to see you at the other site.
Okay. Thank you, Tony. Appreciate that. I want to now bring in our presenter today, Dr. Clark. As I mentioned off the top, Dr. Clark is a member of COVID-19 Oklahoma Project ECHO. She is a healthcare delivery scientist, a healthcare consultant. She has been a palliative care physician who's also practiced internal and pediatric medicine going back to 2007 and is board certified in hospice and palliative medicine. Dr. Clark, we're so happy to have you join us today. And I'm going to go ahead and yield the mic, if you will, to you. Take us away with your presentation.
Sounds good. Thanks, Nick. Can you guys see the screen okay?
Yeah.
Yeah. Okay, great. So really privileged to be here. Like Nick has said, there's a big team at Oklahoma State University that has contributed to really educating our healthcare providers and our frontline staff about, the basics of COVID-19. What do you need to know? Because as we know, the pandemic has been way overshadowed by the infodemic, and there's so much bad information out there. So we've been fortunate. I've had the pleasure pretty much every week, sometimes several times a week, to see Tony's face as part of that group. So know that she and your campus, as a result, are plugged in to the bigger conversation about not only your community there on campus, but also, the county and the state, as well as the globe. So very glad to be here and, supporting Tony and the team in their efforts to keep you all safe. Okay, so we're going to launch in. So I just wanted to give some perspective. So I'm going to take you from that bigger picture around the globe to like what's happening in our backyard. So as you can see here, of the 7 billion people that we have in the world, we just have just over about 200 million cases. We have over 1 billion people now fully vaccinated, which is astronomical. But unfortunately, there's so much healthcare disparity. There's many countries that will not see their first vaccine until 2023 at this point. So we are highly privileged that we not only can talk about getting fully vaccinated, but we're now talking about booster shots, and we'll kind of circle back to that in a second. And you can see the mortality rate and the rate of cases that are happening right now. The US, you can see those numbers there. We're just approaching 40 million cases throughout the entirety of the pandemic, and just over 50% of us are fully vaccinated. Unfortunately, all of us are experiencing a rapid rise in case counts because of a new variant called Delta. I'm sure you all have heard about it, and we'll get to visit him and maybe all of his cousins. The most recent one is Lambda, that's kind of running up behind him. And you can see that we're right around 300 cases per 100,000 over a week's period of time, which roughly translates to about a million cases, or 100,000, sorry, a million cases per week. Deaths, you can see there is 1.7%, you know, kind of, you can see with that mortality rate that's been pretty steady. Oklahoma is unfortunately driving the US pandemic right now. We're in the top 5 along with our colleagues in the deep south. We just broached the 500,000 cases. We've got about 42% of our entire population is fully vaccinated. We just got some updated information. I think it's around 43% now. And we're approaching 400 cases per 100,000 over a week's period of time. So nearly double or close to approaching double where we're at in the United States. And our mortality rate has been consistent as well. So that's just kind of the bigger picture. For those of you who are a little bit more visually stimulated, I'm not sure how more explicit this picture could be, but pretty much the entire country is on fire. You know, this is the CDC's way of tracking things. Okay, so we think about, when we talk about transmission, high levels of caseloads, as a result, hospitalizations and deaths, we measure that by the caseload as well as the percent positive. And currently, this is where we are in the United States, you know, kind of, so you can kind of orient yourself. Here we are in Oklahoma. This is kind of the trajectory of the entire pandemic. So starting, you know, January of 2020, when we had our first case, all the way through the peak we experienced in January. And you can see where we're at right now. And that actually jumped to just over 400 as of yesterday. So we're well past the halfway mark and approaching the 75% mark and well on our way to outstripping what happened to us in January. So just so you kind of know what's happening in your, you know, your community that surrounds your campus, this is what's happening. Here in Oklahoma, you can see how things have happened. This is in the month of June. During the second week, we were at 18.4 cases per 100,000. That jumped to 50 in July. And then August, we got walloped, you know, 360 cases per 100,000. And this is where we were as of the other day. Oklahoma County, where you guys live, is about 345 cases per 100,000. And right now, there's a lot of testing that's occurring. There's a bit of backlog in reporting cases. And so we see this kind of up and down, but we're generally going up. And we had a big, you know, jump in our number of cases across the state today in our reporting. So that number's a little bit higher. The number that's really concerning to me, though, is this, you know, near 85% increase in deaths over this last week. So, you know, lots of stuff happening right now, and just want you to be, not to scare you all, it's just to be very honest about what we're facing as a community and how important it is that all of us do our part. So let's get into the science of COVID-19 a little bit so you understand when you talk about isolation and quarantining and testing and what that all means. So the 3 I's of COVID-19, and poor Tony's heard this 100 ways to Sunday, is incubation, infection, immunity. And you need to understand what that looks like. So incubation is the time that it takes from the time you're exposed to the time that either you test positive or you demonstrate symptoms. And that's the one unique quality that we've never encountered, believe it or not, that COVID-19 has, is that it has the ability to infect someone and have no manifestation of disease. And a lot of that happens in your guys' population. Young adults tend to have asymptomatic manifestations of this. There's asymptomatic, there's people who have mild stuff. We always get confused with allergies. So like Tony said, like Wendy said, like Levi said, like Nick said, if you have a whiff of a splash of something that doesn't feel right, headache, sniffles, sore throat, go get tested, because that's how this thing shows up in your population. There's a group of people that have moderate disease, which is disease where there's a lot of breathing issues, you know, kind of a lot of body aches, severe headaches, and other complications that don't quite require hospitalization, but you're pretty much, you know, taken out pretty well and need to have someone watch over you. And then unfortunately, we're seeing younger and younger people manifest with this new variant called Delta with severe disease requiring hospitalization. That incubation period, so the time you get exposed to the time you show those symptoms or test positive, is about 4 days with Delta. The interesting thing is that you're most infectious the 2 days before that occurs. So almost instantaneously with Delta, from the time you're exposed, you almost become infective. So you have to be very, very smart about where you spend your time and who you're spending your time with, and knowing what risk you're taking on when you do that. So this is where surveillance testing comes into play, helping us figure out those asymptomatic, kind of folks that are in the community so that we can appropriately get them isolated and also identify potential outbreaks. So it's proactive testing, not what we call reactive testing. We have to have both as part of our strategy. As you move into the infectious window, which extends about total of 10 days, sometimes up to 14. And so that's why you quarantine for 14 days and then isolate if you've been tested positive for 10 days, because we know in that period of time, you've got enough virus in your kind of, respiratory tract to spread it to others. And then after that, you move into the immune status, where you have a little bit of natural immunity. Sadly, our natural immunity to COVID-19 is very short-lived and shoddy at best. Some people, we don't know, there's no correlation between asymptomatic version and their immunity, or someone having severe disease and their immunity. We don't know that yet. We don't have enough information yet about titers and what's infectious, what works and what doesn't, which is why we absolutely need to be vaccinated. It's the only way to protect you as well as others in your community. So when you're thinking about, isolation, which is when you're sick, quarantining is when you're exposed, or testing, whether it's surveillance testing or reactive testing, you kind of know why this is the case. And so just wanted to make sure you knew that basic science. So for those of you who are going to the health sciences, this will be widely helpful in your future careers. Okay, what about Delta variant? Well, this guy changed the game. The rules that we had about COVID-19 previously, big ones are, it's 5 to 7 days. We've got a little window of time that you're, before you're infectious and things like that. Kids don't get infected. And it does, yes, there's severe disease, but it's always just in the older population. Those rules have been now thrown out the door. When you think about variants and you talk about them, you want to think about transmissibility, severity of disease, impact on current treatments that we have, and the efficacy of the vaccines. Delta variant is ultra fast. That's its modus operandi. It has about 1,000 times more than the original strain in your viral load, which is over 10 million particles. They are mighty in number. And so it doesn't take much. That, kind of indoors, unmasked for 15 minutes, it's actually a lot shorter with Delta. So that's why it's really important that if you choose to go indoors, masking is essential to complement your vaccination. And if you can, think about being in a space that's better ventilated. The severity of disease. Oh, one thing before I forget to tell you guys, vaccinated people now can carry and transmit this variant. That's one of the reasons why we have to mask. They may not manifest, they may just have an asymptomatic version, but they can infect others at the same rate that unvaccinated people can. And we'll get to the efficacy of the vaccine in a second, but the transmissibility is a really important thing to understand. Severity of disease, previously it was age and comorbidities, whether you're sick with hypertension or strokes or diabetes or obesity or whatever it happens to be. The highest risk now is being unvaccinated. 90%, that's closer, it's somewhere between 75, but most are about 90% of hospitalized patients are now unvaccinated, which includes our kids, unfortunately. We have about 53 ICU beds for pediatrics in the hospital in the entire state, and we have 69 children right now in the hospitals clamoring for those beds because kids are now 2.5 times more likely to get sick with COVID-19. So very, very important to understand that that rule is no longer part of the game. The impact on treatments, we're getting better at understanding the treatment called monoclonal antibodies, which we give to our older adults or people who are immunocompromised. We have had some that have worked and now are failed to Delta, but we have others that we're using as cocktails and they're still efficacious. And convalescent plasma, as you guys can guess, when we now have a different variant, the antibodies that were previously created in our plasma stores are no longer adequate and have a very decreased impact on treatment. This is probably the most important, is that the efficacy of the vaccine is extremely powerful. It's been reduced, though, in a couple of ways. If you are fully vaccinated, regardless whether or not you have one of the mRNA vaccines or Johnson & Johnson's vector vaccine, you are greater than 90% protected against death. You are greater than 70 to 88%, almost 90% protected against hospitalizations. And this is the piece that's changed, is that with the Delta variant, the reduction in the presentation of symptomatic infection, you're still protected, but it has become reduced a bit. This is the most effective vaccine that we have against a virus like this. It is a beautiful, beautiful vaccination that works. The idea is that, one, obviously it can't reduce transmission, but it can protect you from manifesting disease, obviously from being hospitalized and then dying. And in public health, we couldn't ask for more beautiful science. So that's kind of the variant in and of itself. Now we want to talk about kind of like, okay, what are the COVID-19 basics, particularly around vaccination, but what does vaccination look like in a layered, sustained public health effort that a community can commit to? So I've already had COVID and I felt fine. You know, it was nothing big. Why do I need to get vaccinated? Why can't I use my natural immunity? And like I said previously, natural immunity has been shown to be really shoddy. So it's not, we don't know what generates what, and we don't know what levels needed to be protected. So we think you've got about a 3-month window, but that's about what the science is showing. So, you know, get vaccinated, even though you may have shown COVID. The other thing is, if you had COVID previously, you may not have had Delta variant. And so the antibodies that you have for COVID, you know, original or COVID alpha will not protect you against Delta. So another reason to get vaccinated, as it establishes that high level of immune response. The other thing is, I've been exposed, you know, a bunch of different times. Why haven't I got it? Well, one, most people aren't doing what you guys have set up, which is proactive testing, identifying asymptomatic people. So most people aren't going to go get tested unless they're sick. Well, we're lucky enough on your guys' campus that you guys, smart enough group of people around here saying, we got to identify, you know, kind of what's going on in our community. And so if you're fortunate enough, you just happen to have an asymptomatic version and didn't get tested, most people, that's the case. The other thing is there is probably a small population of us that are able to clear this virus, just like some people can clear HIV. It's a very small part of the population, and we're still trying to understand who they are. So those are the big kind of questions I typically get about, why should I even entertain this? One, your natural immunity is pretty shoddy. Two, there's lots of variants that are going around. And three, you may have been fortunate enough to not manifest disease now. But one of the kickers, one of the things that's really hard about COVID is that, yes, you have an acute illness that happens, makes you feel horrible for several days. But now we know this thing called long COVID or long haul or post-COVID syndrome that causes all sorts of systemic problems. And you can actually get long COVID even if you have an asymptomatic version. And we're looking at about 20 to 30% of people who suffer from the disease end up having long COVID. So this is wildly important to protect yourself against. 3 ones that are on board in the United States. There's several across the globe, but these are the ones in the US. The Pfizer vaccine is an mRNA vaccine, which is gorgeous science. The thing is, everyone's, oh, it's brand new, and the FDA kind of cut corners and all of this kind of stuff. The thing is that mRNA vaccine science has been around for 40 plus years. But as we know, in our US healthcare system, if it doesn't make money, we don't often invest in it, sadly. This is the biggest silver lining we have of this pandemic, is that this science was able to come into the light and be seen and used in the way that we needed it probably 40 years ago to combat diseases like cytomegalovirus and HIV and Zika and Ebola and those type of things. And we now have a reason to invest to bring this science to life. So know that mRNA vaccines have been around and have just been waiting for a reason to be used. It will forever change not only infectious disease care, but it will change cancer care. It will change the care of people who have rheumatologic and autoimmune diseases, because this science applies to all of that work. And so I'm very happy to say, as of the 23rd, Pfizer is the very first COVID-19 vaccine that is fully approved by the FDA for people who are over the age of 16. We expect the same thing from Moderna, which is a very similar mRNA vaccine for those over 18. Where that application is in, we should probably know that by Labor Day. Our 12 to 15-year-olds are still in emergency use authorization, but we expect that to happen by the end of the year. But unfortunately, our little kiddos, we won't see until late fall, winter at earliest for emergency use authorization, and then later full use, kind of late next year. The last one is the Johnson & Johnson. It's a little bit different. The 2 mRNA vaccines require 2 shots separated by 21 and 28 days respectively to become fully vaccinated. 1-dose regimen of mRNA vaccines don't work, again, especially against Delta. So you want to get both shots in their appropriate intervals. If you get Johnson & Johnson, way cool, 1 shot and you're done. 2 weeks later, fully vaccinated. So if you're over the age of 18, that is an option for you. It's a little bit different science, and it's a science that we have in many of our vaccines that exist right now. It's a viral vector vaccine. So it uses old technology for a new virus. And so just, kind of comparing those, that's what we typically see. So just so you guys know, you may see, obviously you've talked about Johnson & Johnson, but you may also see the mRNA vaccines around. Big questions that we get, concerns, because we get this horrible infodemic about what's going on, is that typically it falls into 4 buckets. How effective are these vaccines? Do I need a booster? Like what is the efficacy of this thing? We've talked about that already. Highly, highly effective, especially against death and hospitalization and the manifestation of severe disease. Quality and safety. Did we cut the corners? Did the FDA not really make sure that we're, that these are high quality, high produced? The next one is safety. And this is probably the biggest bucket and we'll spend the most amount of time on. And then we'll touch on this idea of public health. Nick has already kind of touched on the political issues that are surrounding our basic public health and, kind of interventions. And I'm going to take a very apolitical stance on this and just tell you what the science tells us about what the layered approach is to public health. So we'll just go through these each section pretty quickly, and then, hopefully wrap up here about 1/4 for questions. I know these are really busy slides. You guys will get these if you want to take a look at them. But these are basic questions that we typically get. Big safety questions. Can I get COVID from the vaccine? Nope, not a live virus. So can't get COVID from the vaccine. If you get a vaccine and get sick with COVID, that means you got exposed before you got your vaccination. Does the vaccine affect my DNA? Nope. Basically, both kind of vaccines are injected into your deltoid muscle in your arm. The vector or the mRNA is moved into the cell and uses the cellular structures to make the spike protein that then generates the antibodies that your body can then recognize and protect when it shows up as a virus. Those are then eliminated very quickly by your body. It never enters the nucleus where your DNA and genetic information are contained. So no, doesn't affect your DNA. What about my reproductive health? This is probably the biggest question that we get from this population on 2 fronts. One, what if I want to have kids in the future? What if I am pregnant? What if I've been pregnant and I'm lactating? Big questions. So despite the large social media blast around this issue, the vaccine does not attack your reproductive organs and or your placenta. Fact. We know that for sure. We know that why? Several reasons. They've studied things and looking at the molecular structures, but when they looked at the vaccination groups, and it was probably the most well-distributed and represented population sample that we have, very, very diverse. When you look at both the placebo group and the vaccination group, there was equal pregnancy in both of them, suggesting that it doesn't implicate fertility. To boot, the American College of Gynecologists and Obstetrics and the Society for Maternal Fetal Medicine have both clearly stated that it's very, very important for women who are considering being pregnant, are pregnant or lactating, to get vaccinated, because pregnancy is actually a high-risk condition for COVID-19. And unfortunately, I've actually bared witness to several babies becoming orphaned in this process because they lost their mother and or losing mothers and their babies together. So it's very important, particularly for that population. The other is if, kind of people are taking birth control, is that going to affect my reproductive health in that direction? No, we know that it will totally work. We've shown some different menstrual changes. So you just be aware that when you get your vaccine, it's normal to have a difficult cycle, usually the first month after your fully vaccinated status. But other than that, it does not cheat. It doesn't appear to impact any medications, including birth control. Next question is, what about blood clots? We've seen in the Johnson & Johnson vaccine, there was a halt by the FDA and the CDC because of development of a thing called TTS, particularly in women under the age of 50. They did a big study on this to make sure that this was, kind of where did this fall into things? And they found that it was a very, very microscopic risk. It still is a risk, but it's one that is far outweighed by the benefits. And so we still recommend this vaccine. It's still on the market. Similarly, there was a relationship between J&J and Guillain-Barré syndrome. And you can read about both of those on the CDC website and what the thoughts were on studying both of those outcomes. So from a safety standpoint, these are the big guys. These are the things that are facts. These are things that we see. These are the direct experience for those of us who are vaccinating and caring for patients and people with it. So from a public health standpoint, is the vaccine increasing the spread of COVID-19? It's not. It actually, we've shown that if we hadn't, India was a perfect example of a situation where we had no intervention at all with vaccinations and how significant Delta impacted them. We had a blunting of that because, a good part of our vaccination, our population was vaccinated. And so it's actually lowering that. Unfortunately, because we were in a race with time of variance relative to the kind of the number of people we're vaccinating, we kind of lost the race on that one. And when Delta came out, that magic herd immunity number went from about 65 all the way up to 85, 90%. And so now we're like in measles, where most of our 90 or more percent of our community needs to be vaccinated in order for us to move from a pandemic status to an endemic status, which is a disease that we can manage on a year-to-year basis. There are a lot of people being forced to leave your professions because of mandates and things like that. This is one of those, it's really interesting from an ethical standpoint. We really honor, particularly in the US healthcare system, people's individual rights and their practice of what we call autonomy. But as someone who as a physician, I may take care of one patient, but as a physician, leader, educator, and administrator, I take care of hundreds of thousands of patients, and I have to be responsible for keeping, the quality and quantity of life for all of those people. And so sometimes the decision-making has to move from autonomy, which is individual decisions, to what we call distributive justice, which really says, how do we preserve the most life and the quality of life for a defined community? And that's where we're at right now about decision-making to first do no harm and do the best by our patient, whether it's at the individual level or at the community level. And then just wrapping up with these last couple of sections from a quality standpoint, I've already talked about this. The FDA basically cleared the decks. Everyone said they went through it too fast. What they did is they basically cleared their entire pipeline, and all they did was really focus on the approval of these vaccines. And so that's why we were able to do it as quick as we did. And again, that science has been around for a very long time. So it wasn't as if they were starting from scratch. The other piece is what's in the vaccine, because people are concerned. There was some discussion about the use of fetal tissues. Being honest about this, one of the most important writings that I've seen is from the University of Nebraska Medical Center. Dr. James Lawler is the head of the biocontainment unit, which is who took care of the Ebola patients and the very first COVID patients in the United States that came off the Diamond Princess cruise ship. He's a Catholic, and he wrote out a very good statement about how cell lines from fetal tissues taken from abortions in the Netherlands and parts of the United States in the early 70s and 80s are used not only in creating vaccines and creating, kind of testing, but it's also the large majority of our pharmaceuticals. This has been part of medicine for, well over 3-4 decades. And so being honest about that, that's a question we often get. I wanted to give you a statement that you could read in depth from Dr. Lawler himself about the use of fetal cell lines and the development of vaccines and medications in our healthcare system. And then lastly, is this really effective? I think we talked about that already. Yeah, 90% effective against death. Anything that prevents you from going to the morgue or the hospital is wildly good, right? And, again, when am I fully vaccinated? You need both shots for mRNA, and then obviously the one shot for J&J. Our viable treatments, kind of are declining, but they are still there. And obviously, if you qualify for those, if you have, kind of a comorbidity, we'll get you where you need to go. And then for those of us who are facing our booster shots, if you've not, kind of are well into our series, boosters are necessary. Our immunity from our vaccinations are declining and actually need to be boosted to deal with the Delta variant. Our hope is that these boosters will last 12 to 18 months, triggering our, kind of the long-term immunity that comes from our vaccination. So if you are a student or faculty member or family members listening, and you've already had your 2-shot series and you're 8 months from being fully vaccinated, you will qualify for a booster. Those of you who are immunocompromised, and there's a list of what those are on the CDC website, you qualify right now. The rest of us will be eligible September 20th. So lastly, big things are, there's no silver bullet. The vaccine is wildly successful, but it needs to be complemented with a whole layered approach. So know your risk. Be careful about where you spend your time, who you spend your time with. Keep your hands clean, kind of know where your hands are, and don't touch your eyes, nose, or mouth, the T-zone kind of thing, because that's how this thing gets in you. Wear your mask. We can't mandate it, but it is the way to protect each and every one of us so that we can actually be in class together. As a professor, I can tell you there's nothing more important for education than being in the classroom, and masks and vaccination are the way that that is going to occur. Take the test. You guys are getting tested. Tony talked about that. Proactive testing, reactive testing, get it all. Get tested as frequently as you can. Watch your distance, again, being careful about which spaces that you share, get a vaccine, and do your part to keep us all safe. So with that, I'll hand it back to you, Nick.
Thank you, Dr. Clark. We are very grateful for your time and appreciate the presentation, your insights, your knowledge and expertise. Thank you so much again for presenting. We do have a couple questions. First one I can answer, actually. It's what is the vaccination rate among the student body and also among the faculty and support staff? Well, I can tell you, I just looked at these numbers. We are tracking them separately for our main campus and our law school. We are just shy of 60% vaccination rate for our students right now. Now, here's the disclaimer on that. That's the people who have identified as having been vaccinated through our secure system, and they've turned in a record of their vaccination. So we're showing that 60% of our student body has turned in their image of their card, essentially. It's about 5 or 6% higher in the law school. For faculty and staff, we're just at about 70% right now, and also about 5 or 6% higher in the law school. So what we're doing as the marketing and communications office on campus is really encouraging people, if you have been vaccinated, to go ahead and submit that record of your card to our secure systems, so that we know what our environment on campus is, and that will really help us design and dictate what our mitigation strategies are on campus. So it's really important that people, if you are vaccinated, share that record with us. We have a question. Do kids who had COVID and are now vaccinated have a lesser chance of getting breakthrough cases?
Oh, that's a great question. Very simple. We don't know. But if you know anything about immunology, you basically got, double layer. So if they've gotten COVID in the past, and it was prior to the Delta experience, which is pretty much everything prior to March, we kind of started really seeing Delta take over as the primary variant in Oklahoma. If you had COVID prior to March, likely that's waned and is not as effective against Delta. But if you've been infected, kind of particularly in June, kind of July kind of thing, you likely had the Delta experience, and you layer that with your vaccination. There's a double layered effect, but what that effect is hasn't been quite measured. But from an immunological standpoint, that makes complete sense.
Here's one. I think, Levi, you may be able to speak to this one. It says, will OCU be reviewing its current green/low level, given the graphics that Dr. Clark was showing, and just the numbers where they are now?
The EOC is currently meeting each week, and each week we actually evaluate the university's operating level at that time. And so looking at local statistics like this are some of our indicators that we look to. We look to community numbers as well as numbers here on campus. We look at availability of resource, isolation housing, staff appropriateness, of access to resources and healthcare on campus. So it's certainly something that we are evaluating and we are considering. And we also understand what we've learned over the past year in those different operating levels. And so understanding that at a moderate level in September 2021 may be different than a moderate level in February of 2021. And so adapting, utilizing what we learned, what worked to protect our campus and community health, and understanding those mitigation factors that perhaps were not as effective in the past. So it is long story long, absolutely. We evaluate that every week and we are looking closely at it now.
Thank you for that. There's a question on the state law that we mentioned. Does it apply just to masks? And the answer to that is no. It's vaccines and also having what would be sort of deemed a vaccine passport program. That for anyone who's curious about that, it is Senate Bill 658. If you just search in your search bar, Oklahoma Senate Bill 658, you can read the text of the bill yourself and educate yourself on what is in there. Here's one for Dr. Clark. It says, are you hearing anything about swollen lymph nodes on the same side that people are receiving their vaccine for women?
Yeah, this gets to mammograms.
Yeah. Yep.
Yeah, that is the case. And so it's recommended that, not to seek your mammograms in the 2 to 3 weeks following your vaccinations. So wait till your series is finished and then wait till you're fully vaccinated. So we typically recommend, kind of 3 weeks. So that, kind of the lymph nodes have a chance to decrease. Yep.
Thank you for that. This maybe Wendy or Levi could take this one. How many cases have you had on campus since kids returning to campus? So that would be just, coming up on, essentially, 2-ish weeks or so maximum here. How are our case numbers looking right now?
I'll take that.
Sure.
Our case numbers are up, but it's expected. We've got everybody returning, coming back. We caught several people with their return to campus surveillance testing, which is great because that stopped them before coming onto campus, and it stopped the spread of them coming onto campus. We have very low transmission in the classrooms, so that's something that we can be very proud of because kids are wearing their masks and because people are wearing their masks. So hopefully we can continue with that. Our numbers have gone up a little bit, but nothing that we can't handle.
Thank you for that. We have one more question in there right now, and it just says some buildings on campus are requiring masks and others aren't. Our official policy on the campus right now is that masks are strongly encouraged in indoor spaces. So I can't really speak to what might be happening in sort of individual circumstances there. But just to reiterate, we do strongly encourage and even hopefully expect people to make the best decision to help keep our campus safe. I wanted to throw it to Dr. Clark for one more question just to finish us up today. And it's something that we, in a previous conversation, Dr. Clark had touched on, and that is, I think, something a lot of people think about, I know I do, is what does the future hold a year from now, 2 years from now, in your medically informed crystal ball? Is COVID like the next flu? Is it going to be with us for years now? What would you say as we close today? What can people expect in the long term here? And maybe if we do the right things and if we don't do the right things, Yeah.
Wow. Okay. So obviously this could change tomorrow, right? So just kind of with what I have right now and what we do know is, sadly, we are no longer, particularly in the United States, there's some places around the world that would potentially be able to actually eradicate this, but because it's a global issue, that's likely, that's very unlikely. So the race between crazy variant like Delta and the rapid vaccination that we needed, we kind of lost that battle. So the idea about eradication and going from pandemic to no disease is no longer an option. So COVID's here to stay, and we'll move into a thing probably by next spring, to be very specific, when we'll move into endemic status, which is it's around, and we'll have enough people in the community, a conditional herd immunity that kind of gets us close to that 95% where we have the large majority of people are vaccinated. And there's obviously a number of people who are living with some natural immunity that get us close to that probably by next spring. And so we'll have to constantly be doing this cycle of, vaccination and masking. It's not seasonal that we can see. So it's very different than flu, behaves very different than flu. And so we'll likely have to get boosters and those type of things. And we'll have variants that come about that we may have to, kind of go into the extremes again. And so our hope, though, is that by next spring, which means we will likely have another surge in the fall, winter, like we did last year. To what extent will be determined based on how many people get vaccinated, frankly, and if we have another variant that tails on the end of Delta that challenges our immunity. Because there are a couple variants out there right now that are escaping vaccination kind of immune status, and hopefully they don't land. There's a couple of them in the United States, but they seem to be we've able to get around them. And so those will be the things that dictate, kind of what the endemic status looks like by next spring. So that's my hope. And so masks are here to stay, whether we like it or not. COVID vaccines are here to stay, whether we like it or not. And the question becomes, how do we use testing as a part of our day-to-day lives in order to identify and honor, both in our employment status and student status, to let people be isolated and quarantined to protect, our population. And so, so that's my 2 cents on that.
Appreciate that. Again, so insightful, and thank you very much for taking time out of your day today to be with us. Thank you to all of the panelists, Wendy and Tony and Levi, for helping us out today. We will have a recording of this, and so if you found it helpful and maybe want to watch it again or want to share with people, we'll try to post that to the university's social media channels. And I believe there should be a way in Zoom where I can share the deck with our attendees today, so we'll look to do that as well. But thank you everyone for taking your time to join us today. Thank you again to our panel, and everyone take care.